be on mute, Farhan.
Oh, yes, Andrea. Sorry about that. Yes, I think we can start.
Okay. All right. Great. Well, I'll just say a few remarks and then turn it over to you, Farhan. So welcome, everyone. I'm Andrea Baer with USAID, part of the private sector team in.
You went on mute again.
Somebody keeps muting you.
I'm not sure what's happening about that. So, all right. So again, welcome. I'm Andrea Baer with USAID Washington on the private sector team, and happy to be co-leading this today with Farhan Youssef, Chief of Party for FHM Engage in Tanzania. And this is our all right. Again, I'm not sure what's happening with the muting. I'll try to keep an eye on it. This is our second monthly Healthy Markets community of practice. And first of all, a big thanks for everyone joining today, and our apologies again for the last minute postponement, but we very much needed to accommodate some Ministry of Health meetings in Tanzania last week. And I also want to share with everyone that you're seeing a slightly different combination of people today, only in that you may notice that Cynthia Eldridge is not on the call. Cynthia was project director with FHM Engage. She decided to move on. So we will miss her, and again, thank her for her contributions, and expect that our paths will all cross with Cynthia again. In the meantime, as you know, with the community of practice, we're taking a local approach. So each month we'll focus on a different country. This month, of course, is Tanzania. And we're also using this new format, which is really intended to be rapid sharing as opposed to one long. And so, so we thank you for your participation and patience as we work with this new format. And really what we want to do, and I'll turn it over to Farhan for his comments, is we really want to switch it up so that more people speak for shorter periods of time, and then we can always come back to the individual speakers and their presentations during the discussion. So feel free to plan that we can circle back later during the meeting session if there's something that you want to comment on further or hear more from an individual speaker on. So with that, Farhan, over to you for your comments.
Thank you so much for that, Andrea. Hey, everyone. As introduced, my name is Farhan Yusuf, and I am Chief of Party for the Frontier Health Markets Engage project in Tanzania. And I think, it's a great opportunity for us to be able to share some of the interesting, private sector related work that's happening, especially for family planning in Tanzania. And, as Andrea mentioned, it was, quite interesting for me as well to sort of think about who I would want to sort of invite to speak here, the whole process of reaching out to them. And I would really like to thank all the speakers who have agreed to speak today, to share their experiences and the different pieces of work that they are doing in Tanzania. It's I would think, a very diverse panel, and we'll hear from a lot of different people. As Andrea said, the idea is to have these short presentations that become sort of food for thought and, allow further discussions. To start off with, I think, first we would want sort of a ground setter, which is what is currently happening as far as family planning in Tanzania is concerned. What does our market look like, and a little bit about what is it that we are doing in Tanzania as FHM Engage to describe the market. So to start that off, we have Sarah Alves, who is a colleague. She will introduce herself and then take it up from there.
Great, thank you, Farhan. Sorry, I'm sitting in the same room as Farhan, so he's muting his computer. So good morning, afternoon, and evening to all of you. My name is Sarah Alfs, and I'm excited to have the opportunity today to share with you about the approach the FHM Engage team is using to advance its understanding of the family planning market in Tanzania. Next slide, please. The work that our team is advancing is utilizing a market shaping or market development approach with the goal to achieve more optimally performing health markets in a sustainable way by investing in systemic corrections to failing market functions. The goal is in turn to deliver improved health outcomes. An optimally performing health market is one that's both effective and inclusive and ensures that the right products and services are available to the right people at the right time and place and at the right price. What we are calling a market description is the first step or task within the diagnose phase along our project's pathway to impact. The goal of the market description is to align our understanding of the FP situation and to understand the role of the private sector, to identify potential market challenges and opportunities, and to reveal areas where deeper understanding through analysis and information gathering is required. Through the diagnostic approach of the current market, we're trying to understand if key health products and services are reaching the populations in need, and if not, understanding why. And then building from this understanding, we can begin to design and prioritize the interventions that address these barriers to access and will be able to shift the market from its current state to more optimal performance. In the deliver phase, we support market actors to actually implement these solutions, and then we're adapting, learning, and iterating along the way. Next slide, please. So through desk review, secondary analysis, and some targeted key informant interviews, the market description is helping us to generate a high-level understanding of the market context, including macro context of health trends, policy shifts, as well as defining key aspects of the core market functions of supply and demand that will support our overall understanding of the family planning market. Unfortunately, I can't present on all aspects today, but hope to give you a flavor of the work that we're doing and the types of insights into the family market we are generating through this approach. While this list is not on this slide is not exhaustive, some of the key questions we're trying to answer around trends in the health system, including new government strategies, major programs or shifts in the health system, as well as questions to help define key aspects of demand and supply, including who's the market serving, who's the market failing, what is the market potential for a particular product or service, what types of providers and entities are allowed to provide these services and products, what's their reach and coverage. Asking these first level questions gives us a starting point for understanding underperformance by highlighting misalignments in areas of market weakness and providing a starting point for beginning to ask the whys that get at the root causes of market underperformance. Understanding these root causes are critical to the design of effective interventions that will ultimately help us move markets. In the following slides, I'm going to give you a quick overview of this macro picture for Tanzania and then share some of the questions that we've been asking ourselves as we examine newly released Tanzania DHS 2022 data and show how this questioning is informing our understanding of the market. Next slide, please. So some background on Tanzania. So Tanzania is a very fast growing population, which has grown by over 37% over the last decade, and it's very young, with 70% under the age of 30. Tanzania has been experiencing steady economic growth, and in 2020, it graduated from low to lower middle income country status. And while this is a great achievement, this implications on the types of external funding sources it will be able to access in the future. In the context of donors signaling decreasing commitments over the coming years in areas such as family planning, and in combination with a burgeoning young population, it becomes clear that some of the government's free-for-all policies for health areas, including family planning and maternal and newborn child health, are not financially sustainable, and point to an immediate need to start developing and operationalizing strategies that are looking at total market and getting more people who are able and willing to pay. Next slide, please. When we look at the Tanzanian health infrastructure, we see that there's a robust private sector that can be harnessed to achieve improved health outcomes in priority health areas. While the government owns the majority of lower level health facilities, including health centers and dispensaries, the private sector owns the majority of hospitals and pharmacies and accredited drug dispensing outlets, which number over 20,000 across the country. These different service delivery points lend themselves in different ways to ensuring access to modern contraceptive methods, with private health facilities serving as an important source for female sterilization, and pharmacies and ADOs an important source for short-acting methods like pills and condoms, with the potential to deliver more methods if national policies can be changed. Next slide, please. When we look at the health financing picture in Tanzania, we see that per capita health expenditure at $36 is quite low compared to some of our neighbors and is well below what's required to achieve universal healthcare access. This macro picture makes us pause and ask what we think will happen to the family planning market in the face of declining donor funds and the levels of overall government health spending, and makes us think about how we can begin to prepare for these anticipated changes in the financing landscape to ensure continued access to FP services and products. Next slide, please. So very excitingly, Tanzania DHS 2022 key indicators released earlier this month with the expected full survey results sometime in April. Examining the DHS data helps to begin to tell us part of the story about who the family planning market is serving, and starts pointing to who and where the market is failing. Next slide, please. So when we looked at trends in modern contraceptive use amongst married, which is the graph on the left, and unmarried women, which is the graph on the right, we saw that between 2015 and 2022, modern contraceptive use slightly declined amongst married women, but declined significantly from 45.8 to 36.2 over this period amongst unmarried women. Interestingly, particularly amongst unmarried women, there's a steady increase in traditional methods over this time as well. When we look at this picture, we ask ourselves, why is modern contraceptive use declining? Were there supply issues with unavailability of preferred modern methods over this period? Are modern methods not meeting the needs and preferences of women in Tanzania? So DHS is not necessarily going to give us all those details. So then we turn to conversations with different market actors to explain some of these trends. We look at trends in public sector volumes of commodities. We speak to provider on the front lines of the front lines providing services to these target populations to begin to fill in the story. And the picture that begins to emerge is that I think there are a number of factors contributing to these declines, including anti-family planning messaging that proliferated in the last government regime over this period, COVID-19 supply challenges, and provider bias to not recommend modern methods to women without children due to side effects and fears of future infertility, among others. Next slide, please. This is a slide. This is a map of Tanzania showing the variations in modern contraceptive use across regions. When we look at this picture, we ask, why are some regions performing better than others? Are there any lessons to be learned? From a project perspective, this map also helps us think through areas of opportunity, thinking about where low rates of modern contraceptive use and higher unmet need overlaps with a robust private sector that may be able to serve some of that demand. Next slide, please. So this is the final data slide that I'll show for the purpose of today, but just wanted to highlight that in 2022, we saw implants surpass injectables as the most used modern contraceptive method in Tanzania. We gather that, again, this shift in the market landscape is due to a number of factors, including increased number of health providers trained on long-acting methods over this period, less availability of injectables in the public sector over this period, among others. Currently, there's no real private supply for implants in Tanzania, and the women in the highest wealth quintiles who may have some ability and willingness to pay are receiving them for free. Our team has been speaking with market actors like DKT, who have a registered implant in country, to understand the barriers to private supply, and are trying to see how our project is best positioned to push forward these efforts to ensure products and services are accessible through different channels that meet the varied needs and preferences of our consumers. Next slide, please. So market description is really just the conversation starter, and it's helping to point to areas where the market is underperforming across supporting functions of rules, regs, rules and regulations, stewardship, financing skills, market intelligence, and information. Identifying these issues really helps to glean areas of opportunity where our project is best suited to facilitate conversations and actions that will help to change the market and ultimately lead to improved health outcomes. So thank you very much for your attention. I look forward to sharing more about the market description work and other activities as our work advances. Thank you.
Okay, thank you so much, Sarah, for setting us up with that introduction to the FP market in Tanzania as we are seeing it right now. Now we move on to our rapid summaries for today. Just to remind all our presenters, you have 5 minutes to share your some kind of ongoing plan practice approach. I would like to request that if you are able to keep your video on, then please do so. And to our participants, if there are any thoughts, if there are any questions, please feel free to put them on the chat so that, by the time we get to the discussion time, we already have those questions there so we can save on time. And if there are any particular topics of interest, as Andrea mentioned earlier as well, that you would like to deep dive into, I think we can have a little bit of discussion about that towards the end of the session as well. We are keeping time, and so, participant or speakers will be alerted when we have 1 minute to go from those 5 minutes, and, please try to keep in time. I think moving from there, our first speaker for today is Monica. If you can please take us through.
Good morning, good afternoon, good evening, everyone.
Monica, you are on mute.
Oh. Oh, really? I've unmuted myself.
I can hear Monica.
I can hear her.
We still can't hear you.
Can you hear me now?
I can hear her.
I can hear you.
Sorry, it's a problem. We go on, Monica.
Okay, so good morning, good afternoon, good evening, everyone. It's lovely to have you all in this session. As introduced before, my name is Monica Bernard. I am the founder and director of programs for Healthy Shield Foundation. So the purpose of our presentation today is to showcase our work and also to show you the problems that we're trying to solve and the solution to the problem. So I will take you through the background, the problem solutions, and finally show you our team. Next, please. So who are we? We are a non-government organization located in Geita, Tanzania, and we work to improve sexual and reproductive healthcare services, including family planning. Our ultimate goal is to save lives by contributing to social behavior change and also increasing uptake of sexual and reproductive healthcare services with a focus on contraception services. Next, please. So, what is the problem? We all know that access to sexual and reproductive healthcare services is tough. As an organization, we have learned that individuals, particularly those in remote areas, have inadequate knowledge about contraception. And we have also learned that they have limited access to qualified healthcare professionals who are the backbones for a functioning healthcare system. Some women or women of reproductive age walk long distance just to search for sexual and reproductive healthcare services. And even if they arrive at these healthcare facilities, they might not find the type of contraception that is more convenient to them. And this leads to 29% of women of reproductive age with unmet need for contraception services. Next. So what do we do as an organization? We work to bridge the knowledge gap and bring sexual and reproductive healthcare services, including family planning, closer to the user. And we do that by strengthening the capacity of healthcare workers, peer educators, accredited community pharmacists on contraception services. And we also work to strengthen a referral mechanism to ensure that clients who need proper contraception plan are being referred to sexual and reproductive healthcare clinics, or for those who need medical refill are being linked to drug shops that are close to them. We also ensure that our clients have proper access to healthcare professions, and by doing that, we increase the uptake of high-quality sexual and reproductive healthcare services, and particularly to women living in remote areas. Next. So as explained in the previous slide, our connected service approach puts adolescent girls, young women, and youth at the center of our services. We provide capacity building, and to the clients, our primary beneficiaries, who are the community health workers, the accredited drug dispensers and owners, and the peer educators in the community. We train them on contraception services or family planning. And after training them, they're being tasked to go and disseminate or raise awareness in the communities that they're coming from and identify clients who need further contraception services. They link our clients to sexual and reproductive health care clinics and drug shops for counseling and advice, products and services. Next, please. So our current project is in secondary school, whereby we work with adolescents and youth. And at the community level, we work with young mothers. So through our existing structures of community health workers, peer educators, and accredited drug pharmacist owners and dispensers, they provide education to adolescents and young women in the community level and at secondary school level, and also connect them to the drug shops or sexual and reproductive health care clinics in Data region for services and products. Next. So we are a multi-talented team committed to solving existing reproductive health challenges in our community. And our team consists of pharmacists, program managers, accredited financial managers, and human resource managers. And as a team, we are looking for partnerships. We are looking to engage private sectors and non-government organizations and the government to join efforts in order to improve reproductive health outcomes in our communities. So next. Next, please.
Thank you so much, Monica. I believe that was the last.
Yeah, so I had a thank you slide. That's very okay. So that marks the end of my presentation. Thank you all for your time and listening.
Thank you, Monica, for sharing that and for keeping in time. I would like for us to move on to our next presenter, who is actually Dan from Maisha Meds. Dan, please go ahead.
Thank you so much, Farhan, and thank you for inviting me to speak. So I'm here to present on behalf of Maisha Meds. Maisha Meds is a Kenyan founded health tech startup with operations now in Tanzania, Uganda, Kenya, Nigeria, Zambia. The way in which we sort of try and approach improving access to care across our network is we design software solutions to support the facilities, and then we also have developed a payments infrastructure to allow us to directly influence the behavior of the provider at the last mile and to provide subsidies direct to the point of the patient accessing care. We then evaluate those claims made by the facilities, and so we provide also sort of a health insurance solution for the uninsured. If we could go to the next slide. So Maisha is building a market insights and payments platform to shape private sector treatment. This is based initially, what we do is we build out a network of facilities that are using our point of sale system, which is a business management system for the private facilities. So using this, they log every sale that they make. It tracks their profit, their inventory, their expiries of stock. And then that data is uploaded to the cloud. Using that data, we're then able to work with global health funders to design programs to shape the quality of care provided in the private sector. The facilities benefit by receiving access to the subsidies, incentives, credits, and stock. In return, they enroll patients in our programs. The patient verifies their identity, pays a small co-payment to the facility, and receives a subsidized quality care that is captured through our system. We then verify the transaction and pay the pharmacy or the ADO via a mobile money payment. So every month, about 600,000 patients will walk through one of our facilities, and we pay directly for about 15,000 patients to access malaria, injectable contraceptives, and HIV care. If we could go to the next slide. So Today, we've installed our software in over 400 private facilities in Tanzania. We have 122 pharmacies, 280 ADOs, 20 clinics. Data from these facilities is updated to our system on a daily basis. We're also working on trying to improve access to working capital for these facilities. And these facilities served 1.2 million patients in the last 12 months, and 32,000 of these patients accessed hormonal contraception. For the purpose of this presentation, I'm not going to talk about condoms in the private sector. So as you can see, we've grown significantly in Tanzania in the last 24 months. If we can go to the next slide. Oh, sorry, before we go to the next slide, I just wanted to, do you mind just winding back? I just wanted to call out a little bit our distribution here in this on the left. As you can see, we're quite strong around the lake area. In some of the areas that I think were highlighted on the previous slide as having quite low access to modern contraception is actually where we have a reasonably high concentration of facilities as well. If I can move to the next slide. So based on the data from our point of sale system, emergency contraception is the fastest moving, best selling product in the private sector. So I know that the DHS survey doesn't necessarily capture EC in quite that same way. But what we find is that adolescent girls and young women are much more likely to be accessing care through this channel. And they're also much more likely to be accessing shorter acting methods. So what we see as what's shaping the private sector looks quite different to that DHS map of commodity usage. We think this is really important because this high reliance on on-demand emergency contraception has a much higher failure rate. And in terms of the cost per CYP being paid by patients at the last mile, it has a significantly worse outcome. What we also notice is that family planning commodities in Tanzanian private sector facilities only account for about 2.7% of sales versus 4% and 4.5% in Kenya and Uganda. So the Tanzanian private sector for family planning at the facility level looks less developed, we would say, than similar facilities in Kenya and Uganda. And one of the ways in which this sort of presents itself is lack of cyanopress, DMPA-SC in the Tanzanian private sector, which sort of makes it more challenging to increase uptake of the longer acting injectable methods. If we could go to the next slide. So this graph is based on 32,000 patients who accessed care. So in the last year, we have run a randomized control trial in Kenya, looking at using discounts and incentives delivered directly to the facilities through our network to drive uptake of DMPSC. These are preliminary results, but we've shown an over 400% increase in usage of longer acting methods. And there are different arms of the study, and they have different amounts of subsidy and incentive we used in the different arms. And I can go into more depth, or actually more accurately, I can get the academics who performed this to go into more depth. But yeah, this is a little bit about the work that we're doing. We'd be very keen to also take this to Kenya. Next slide. And I can see Farhan motioning to me to speed it up. So I'll just wrap it up by saying we're interested in expanding these programs across 4 countries. We've received $9 million of scale-up funding for our malaria programs from the Gates Foundation. That doesn't cover Tanzania currently. We're very interested in doing something around family planning, and the aim is to really bring the price down as low as possible to reach the maximum number of women, and actually pay on an outcomes basis for each person that we can prove that we've treated. Thank you very much, Farhan. Apologies for going over.
No worries, Dan. Thank you so much for that. Quickly moving on to our next presenter, Maureen Dekana, who is actually from the predecessor Shops Plus project that FHM Engage is really building on. So, Karibu, Maureen.
Thank you very much, Farhan, and thanks for including us in these discussions. As introduced by Farhan, my name is Maureen Ogadandekana. I work for Abt Associates and previously led the Shops Plus project in Tanzania. So you could say, what I'm going to do here today is to take you to a little trip into the past. And Farhan, as you mentioned, I think it's been really exciting to see, as Sarah was presenting, how some of the work we did under Shops Plus has been taken forward. And it's also really exciting to see some of the new DHS numbers and very proud to know that we contributed to some of those results. So Farhan, next slide, please. Thank you. Next, Farhan. Great. Yeah, so the first piece of work I'd like to sort of present to you or talk to you about is some work that the project did around market development's approach. So we adopted the original Springfield Group framework, making specific modifications to apply it to the family planning market. So these specific modifications included adding a higher level examination to how the market facilitates sustained and equitable use of family planning in Tanzania. And we also added specific considerations around stewardship. Next slide, please. So to test the framework in Tanzania, we focused on 3 family planning methods. And we focused on these methods because they make up about 72.6% of Tanzania's method mix, at least then they did. And these 3 methods included combined oral contraceptive pills, implants, and injectables. And applying this framework helped us to understand 2 issues. Number 1, it helps us to understand the complex interactions and networks amongst market actors. And then secondly, it helped us to identify where, why, and how systems may have been failing to serve Tanzania's family planning end users. So in terms of approach, we first identified high-level trends in use and then examined areas of underperformance in core supply and demand functions of the market. Following that, what the project did is that we used data and information from previous, TMA, total market approaches work that was done by the project, and also data from DHS data tools such as the FP Market Analyzer and Track 20. And we use this data to identify population segments who are underserved by the family planning market. So next, the project conducted key informant interviews with a select group of stakeholders, and these included key government stakeholders. We also talked to market actors. And what these conversations did is that they helped us to identify root causes in several areas, such as policy, financing, as well as other supporting functions. Finally, we determined the most actionable and feasible interventions needed to address the identified root causes. Next slide, please, Farhan. So across the methods that we examined, the project observed stagnant use amongst the upwardly mobile women. And what we mean by this is that when we looked across the different methods, there was either a plateau in use, a steady decline in use, or much less growth amongst more urban women, amongst educated women, and amongst wealthier women. Next slide. So across the 3 methods examined that I spoke about earlier, some product-specific supply challenges and opportunities were identified. So I'll quickly run through some examples. So something we identified in the oral contraceptive pill market was that the market was experiencing market challenges that were caused by shifts in the social marketing space. The injectable market was dominated by public sector, but we recorded market entry potential by certain private sector actors. And finally, one I'd like to highlight was that the implant market was flooded by public sector commodities that were available in both the public and the private market. Next slide, please. So in addition to all this, the project identified root causes and opportunities that can be considered to address supply and demand challenges. I won't go into this today, but happy to discuss further. Next slide. So as a final step, Shops Plus developed a roadmap, and our hope for developing this roadmap was that it would be used as a reference for private sector market work in the country to make targeted investments. So the roadmap covered 4 areas. Just to highlight them quickly, it covered investing in demand, generating new market data, strengthening policy framework, and finally empowerment of Tanzania's private sector. Thank you. Farhan, I believe that was my last slide.
Yes, Maureen, thank you. You can move on with the other presentation as well. Thank you.
Thank you very much, Farhan. Great. I think we can move on to the next slide. I've already introduced myself. So, we were also asked to share a piece of work that we did around or implemented to expand access to implants through Tanzania's private health facilities. So that's what I'll be talking about next. So this is just a snapshot. Sorry, Farhan, go back to the previous slide. Thank you. Yeah, that's perfect. So in Tanzania's family planning market, implants are the second most prevalent method. Then, at the time when we were doing this work, implants were the second most prevalent methods. And basically, just to give you a snapshot, in this graph that I'm showing here, the dark green bar represents the total number of women on each method, while the inner light blue bar indicates the proportion or the percentage of women accessing that particular method from a private sector source. So this graph is a representation of the substantial role that private sector plays in the provision of short-acting methods. But when you look at the same graph in terms of longer-acting methods like implants, you'll see that the implant market is more limited. So at this time, the private sector was serving just 11% of all implant users in Tanzania. So this limited role had 2 implications. First, the first implication was that it put the burden for absorbing the growth of implant use amongst women in Tanzania squarely on the public sector. The second implication that we noted was that basically it has the potential to limit, or had the potential to limit, access to one of the most popular methods for women in Tanzania, especially women who would prefer to get that method from a private sector source. So these 2 implications basically formed the basis of our work. Next slide, please. Great. So through its work, Shops Plus sought to answer three questions. One, we wanted to determine how access to implants through the private sector could be improved in Tanzania. Secondly, we wanted to understand what the current approaches for building capacity of private sector providers was to deliver implant insertions as well as implant removal. And finally, given the limited private sector market, we wanted to determine if private sector supply chains for implants could be strengthened in the country. Next slide. So at the start of this work, the project conducted a rapid assessment to identify opportunities as well as to identify barriers to private sector participation in the provision of implants, both insertions and removal. And the assessment identified 3 challenges that we'd like to highlight. The first one was, limited training opportunities for private sector providers. Secondly, we determined that there were challenges with access to affordable commodities. And, the third one was pricing pressures that created challenges for sustainable service delivery models for implants at these private facilities. Next slide, Farhan. So the Shops Plus project identified and sought to address these barriers that private providers faced. So of course, along the 3 lines that had been identified. So our implementation focused on training private health providers. We also had work that focused on commodity access through public-private partnership models. And then we also worked on pricing guidance from district authorities that allowed private sector providers to charge fees. And these fees were meant to cover non-commodity related costs for implant insertion and implant removal. And the reason why I emphasize this is remember that the commodities were being sourced from the public sector supply chain. So obviously there's a lot more information that we can share regarding our approach, but given the time, I think let's just move on to the next slide and we're happy to further engage on this. Thank you. So a little about the results. In the 6-month pilot period, in total, the graph we are showing right now shows the results from 39 trained providers. So these providers delivered 1,390 insertions, and 359 implant removal in the 6-month pilot period. So referencing the slide, again, the graph on the left shows insertions by month, and the one on the right shows removals by month for providers from 2 regions. So the 2 regions highlighted here are Dodoma and Arusha. Next slide, Farhan. So from the experiences from this work, the Shops Plus project highlighted lessons for future, private sector models. This would be my last slide. I'll be very quick. So first was on considerations by government to build more sustainable training options for private sector providers. And of course, one of the most common requests we got was building, training options that don't have them away from their facilities for a long time. So secondly, the limited private supply chains for implants requires both global as well as local solutions, and of course needs to be considered through a market shaping lens. I'm sure this is work that is continuing. And then from our highlights, one of the local solutions to consider that we highlighted included pairing efforts to build the capacity of private providers with efforts to actually increase targeting of free implants. And then finally, in conclusion, the ability to charge a realistic price. We identified that this is likely to be, one of the keys to sustainability and viability of these markets, and the sustainability of implant provision through the private sector. So therefore, strong considerations need to be made, to both how to bring down the cost of implants in the Tanzania market, as well as how to incorporate financing solutions. Thank you very much, Farhan. I'd like to stop there.
Thank you so much for that, Maureen. Moving on to the next speaker, we have Dr. Amon.
Thank you, Farhan. Good morning, everyone. I'll be sharing the findings from our ongoing study that is called Ambassadors for Health. And with Ambassadors for Health, we have the bolded ADO, which stands for Accredited Drug Dispensing Outlets. And our main objective in this study is to see how best you can reach young women through girl-friendly drug shops in Tanzania. Next, please. So this study is a collaborative work between Health for Prosperous Nations, that is a local NGO in Dar es Salaam, Tanzania, as well as the University of California, San Francisco. And we were driven by the fact that adolescent girls and young women face a dual threat of contributing enough to new HIV infections, as well as unintended pregnancies. And so we are struggling to know how best can we make HIV self-test kits and contraceptives available to these young women. And knowing that we have a number of accredited drug outlets, about 13,000 in Tanzania, we thought if we could make this girl-friendly, there could be a good tap for these young women to access sexual reproductive health services at their first point of access. And in so doing, we, next please. We designed a mechanism, an intervention using various methods, including a human-centered design, behavioral economics, as well as implementation science. That was collaborative between the young girls themselves, and we had the youth advisory board from them. And together we developed a loyalty program that is a Malkia Club or Queen Club, which we tested in a pilot, and we are now testing it in a larger study. So basically, the Malkia Club is a loyalty program whereby whenever a girl pop into the ADO for shopping, she is given this card, which give her a chance to earn enormous prizes from the mystery bag on the right. But also in this ADO, which serve this intervention, we have these product displays where the girls can appreciate various sexual reproductive health, including implants, condoms, UPT, and the like. But also on the back of the card, we have those symbols, some representing the UPT, one representing the emergency contraceptive, the oral contraceptive, as well as the condom, so that girl can quickly ask for these using her card. Next, please. So we tested this loyalty program as a cluster randomized trial in 20 adults in Shinyanga that were standardized into 1:1. That is 10 shops implemented the loyalty program, and 10 shops had the business as usual sales. And this was done within 4 months from 2019 to 2020. And these are the results. So we can quickly see that the shops which implemented the loyalty program had a higher number of customers, had a number of about 1,500 girls interacted between them, compared to actually 5,050 compared to only 1,600 in the comparison group. But also we had the adults which implemented Malkia Club distributing more HIV self-tests compared to the comparison groups, but also we had them distributing more contraceptives, about 6,000 compared to 199, the contraceptives of the control group. And similar, for those who inquired other contraceptive methods that were not, could not be given readily there, the shops had mechanism to refer them for these in the nearby facilities. And we saw that, again, the Malkia Club shops implemented quite a number of referrals compared to the comparison shops. Next. And so, next. From this pilot study, we learned that contraceptive uptake as well as HIV self-test can be facilitated with great acceptability using these adults. And both the girls were excited, and the shopkeepers, the drug vendors were also motivated. And so we thought that Malkia Club has a potential for sustainability, because it met the standards for both the girls and the shopkeepers. And given that, we had a chance to win a grant to scale it further and to assess in the effectiveness study. Next, please. So currently we are running a comparative large study, which is trying to assess the effectiveness of the Malkia Club, but this time using clusters with the endpoint of HIV diagnosis as well as pregnancy among AGI. We also have another objective of verifying behavioral change and to describe demand-side pathways through which Malkia Club may be influencing AGI, but also we wish to determine how implementation challenges or innovations can relate to program effectiveness for scale-out. Next. So this is an ongoing study. We intended to randomize 40 wards where we could have at least 3 adults in each ward. And so we intended to have about 120 adults in total from the 2 regions, that is Mwanza and Shinyanga. You can recall that the pilot study was done in Shinyanga only. And so we expect to implement this intervention for 2 years. And our primary outcome, as I said earlier, is HIV diagnosis and ANC registrations. So we have managed to enroll 40 interventions, 78 shops, all right, and 72 shops in Shinyanga. Next. So those are the quick findings just from one region within 6 months of implementation. Thank you.
Thank you so much for that, Dr. Amon, and I'm sure we'll have a lot of discussion after we are done and we reach to that stage. Going on to the next speaker, we have Dr. Mary from, First, we have Dr. Stephen from Momentum Project. Please, Dr. Stephen.
Hi, my name is Stephen Forsyth, and the Momentum Project conducted a pilot costing study in 3 countries, the DRC, Nigeria, and Tanzania. The costing study focused on the cost of ANC, PNC, labor and delivery, and family planning services in each of those 3 countries. For each country, we targeted 3 public facilities, 3 private for-profit facilities, and 3 nonprofit facilities for a total of 9. We know that the costing is particularly important for decision makers as it helps to inform budgets and resource allocation decisions. We also know that when it comes to the private sector, whether it's the for-profit or nonprofit sector, there's very often a scarcity of cost data. This scarcity makes it particularly difficult to make decisions in terms of delivering family planning and maternal health services. Therefore, for the purpose of this analysis, we piloted a costing study at both public and private health facilities. with the objective of informing budgeting and resource allocation decisions. The analysis was done in 3 areas: Kinshasa in the DRC, Ebonyi State in Nigeria, and Dar es Salaam in Tanzania. Next slide, please. As part of this process, we collected data from 3 different sources. First, we conducted interviews with program managers at each of the individual facilities. We assessed the staff members who were delivering services and the amount of time they spent in delivering services. We determined the drugs and supplies used for each client, and we also included estimated indirect costs such as water, electricity, building space, etc. We also relied on data from other sources to validate the information collected from the facilities. And finally, we conducted qualitative interviews with key informants to obtain a clearer picture of the perceived role of the private sector in delivering family planning maternal health services. Next slide, please. The following figure shows the number of family planning client visits by facilities. As it shows, the number of FP visits tended to be much higher in public facilities, shown in orange here, than in the private facilities, shown in blue and green. The busiest facility was Kimara Health Center with 2,833 visits over a 3-month period of time. And 2 of the facilities, CISA Dispensary and Berhani Charitable Hospital, had no FP clients over a 3-month period of time. Some facilities like Arafat had only 8 family planning visits over the entire 3-month period of time. Next slide, please. This figure shows the wide variation in family planning services provided, and these differences in family planning methods is likely to have a large impact both on costs and on efficiencies. Next slide, please. If we look at how busy each staff member is, we see that generally the number of visits per clinical full-time equivalent was highest in the public sector. In other words, the public sector had the largest number of visits, but also had the busiest staff members. Next slide, please. This figure shows how salaries compare at different types of facilities. We see that the salaries at the salaries of clinical providers are somewhat higher at the 3 of the 4 private facilities, although the differences in this case are not large. Next slide, please. This figure shows the cost per person reached with family planning services, which generally ranges between $4 and $5 for public facilities and $6 to $7 for private facilities, with the for-profit and the nonprofit facilities generally being quite similar. The biggest differences tended to be the cost of drugs and commodities, which are generally higher in the private sector. Given the existing pressures in the public sector to expand family planning services, the graph suggests that if the private sector were able to access drugs and commodities at the same price as the public sector, they'd be able to provide costs at a similar level. Ultimately, a larger costing studies with the existing costing tools would be able to confirm if this conclusion was correct. Next slide. In conducting this exercise, we noted a number of important lessons learned. First, we noted the importance of selecting experienced and knowledgeable consultants in the data collection process. In this case, we worked with only 1 local consultant in each country. In the case of Tanzania, that was a health economist from MUHAS. And this helped in terms of data consistency. Now, as we increase sample size, there's likely to be an increasing need for more data quality controls as we get more data collectors. Second, we determined that open-ended questions were not typically the best approach for identifying resources utilized. For example, if you go to a facility and ask, what supplies did you use? Often we get incomplete answers. When, on the other hand, when we ask more specific questions about items that were or were not used, we got better results. Third, we collected both direct and indirect cost data, and we found that delving into the indirect costs were particularly important as they provided important and clear picture of how resources were being incurred and who was paying for them. And finally, we found that the qualitative interviews were helpful, but we believe that they would have been better performed after the quantitative data had been collected so that we can identify some of the issues. Next slides, Thanks. I'd like to thank USAID and Momentum for supporting this effort. As noted, we think that this study has been particularly valuable as countries choose to scale up costing and develop a much clearer picture of how family planning resources are being utilized. Thank you.
Thank you so much for that, Dr. Stephen. And now moving on to our final, presenter for the day, Dr. Mary. Dr. Mary, are you? If you are speaking, we can't hear you.
Can you hear me now?
Yes, we can, but there seems to be an echo.
An echo, yeah. How about now?
It's better now, yes.
Okay, perfect.
Oh.
Thanks for the invitation. And thanks everyone and the presenters. It has been so diverse and eye-opening to listen to everyone. Hopefully I would be brief and give you a sufficient insightful presentation about healthy entrepreneurs whom I'm presenting today. So my presentation is about improving access to family planning methods, modern family planning methods through HE Healthy Entrepreneurs model, focusing on rural, hard to reach areas, specifically in Tanzania today. Next. So who is healthy entrepreneurs? So our vision basically is delivering basic health care for all. Next. And our mission is reaching that vision through training and equipping women and men to become community entrepreneurs or community health entrepreneurs. Next. So where we are, we're currently operating in the following 5 countries. Our biggest operation is in Uganda, where we have trained community health workers, reaching the number of 9,500. We're also operating in Kenya, Tanzania, Burundi, and Burkina Faso. Next. So as I have mentioned, in all of those 5 countries, we have collectively over 15,000 community health workers. We are active in the following countries: Uganda, Kenya, Tanzania, Burundi, and Burkina Faso. And on the estimation that each community health worker is serving around 1,500 people or 200 households, we have reached over 18 million people in rural communities in the countries of operation. Next. So what is the challenge that is facing us that we try to solve? So in sub-Saharan Africa, over 600 million people are living in hard-to-reach areas and remote villages. So the distance is far, and that results for the nearest health facility, and that results in poor knowledge and low demand creation. The expenses that the patient or the family will invest into reaching that facility is much higher than acquiring the medication or the family planning method or the commodity that they are trying to get. Most probably those expenses are out of pocket. Even if the commodity is supplied by the government for free, the expenditure on staying in a different village or on transport is 100% out of pocket. Next. So the idea came that we need to be as innovative as hard the environment that we're operating in is. And then we decided to work with community health workers. So it's a private sector model that recruit, train, and equip community health workers. And once we recruit them and train them and equip them, they become community health entrepreneurs. Using those community health entrepreneurs, we would be able to reach the very last mile person in the village, in the rural areas, and even as suggested recently, to target within the same model the urban poor as well. So those entrepreneurs offer those commodities at a very sustainable but low price to the end consumer. By using private sector, we want to make sure that the supply chain is efficient, that we never run out of commodity, and also we save the consumer the hardship of traveling or going to the facility where they will end up not getting or offer the services that they went for. We support them by a mobile phone and 2 applications that are now actually 3 applications, a third one that involve e-dispensing to allow us to monitor the supply chain, what is being offered, especially for the more sensitive commodities. Next. So those are range of products that we offer through the community health worker. And when we talk about private sector in sub-Saharan Africa, we cannot keep it as traditionally as we think about health facility with walls and desks and examination room. We need to go beyond that. And if we talk about Tanzania specifically, we need to think about community health workers and others to deliver the commodity that we wanted to reach the last mile. Next. So this is basically our model that we will have a supply chain that reaches out to clusters of trained community health workers, where then they take it to the last mile village. Next. So we have conducted a couple of researches through our pilots and through our operation. And as you can see, the income is increased by 100%. The penetration of the community is doubled. The health awareness and demand creation is also doubled if you're using similar model to HE. Next. And due to COVID-19, we sensed the need to even evolve or increase the health access through our network and through our supply chain. And then came the need and the idea for having a telemedicine or telehealth department. And the telehealth department is a group of clinical officers and medical officers that are available, not 24 hours yet, but throughout the day to support those community health workers if they have questions, if they needed to support the patient in any complicated case. And that will cover actually maybe HIV, ST counseling, family planning, infectious diseases, NCDs, and others. Next. So our vision for growth in Tanzania, we're aiming to have similar operation to Uganda, which is our biggest operation. And if we train by 2025, if we train 10,000 community health workers, which will become community health entrepreneur, we will reach over 20 million of the Tanzanian population. So which is actually half of the rural, as the rural population of Tanzania is 2/3 of the population, which reach 40 million. Next. So in the previous slide, we had Geita in red because this is where we started our operation in Tanzania as a small scale operation, which we are hoping now to expand. Those are few numbers that I'm sure we all know, but the fertility rate in rural areas are double that of the urban. Hence comes the need to target those rural populations in demand creation and understanding the trends in their market and understanding what to actually affect them and how to reach them with sustainable and low price, as mentioned by Maureen also, realistic pricing for those populations. It's not only the private sector that is in the urban. Next. So this is our impact in Uganda. I won't go through it, but I will be open to discuss those figures after. But what we have noticed is very important to share with all of you. The public commodity provided by the community health worker at a small service fee was much more fast-moving product than purely private sector commodity. And this is what we have noticed. It worked for us better than actually going to the facility or going to private sector. Next. Those are some of our partners, and we are proudly one of the biggest implementing partner for the Ministry of Health of Uganda, and we are hoping to be the same with Wizara ya Afya in Tanzania, with the help of other IPs and donors, to enable us to reach that last mile woman or man needing our services. Next. Thank you so much for listening for my presentation, and thank you again for the invitation.
Okay,
Thank you so much.
I don't know
why
I'm
I'm
facing
facing
an
an
echo.
echo.
Is this better?
Let's see, and maybe try again, Farhan.
Is this better, Andrea?
I think it is, yeah.
Okay. Thank you so much to all our speakers, for all these presentations. Before we move on to the discussion, I do believe we want to give some time to anyone, because we had reached out to quite a few other market actors. Some of them were not able to bring forth any presentations. Is there anyone in the group who perhaps, is doing some work in Tanzania and wants to share their updates really quickly, informally in 2 or 3 minutes? We just want to allow people from the group to be able to do that. If you are able, either you can raise your hand or just unmute and, tell us about the work that you're doing. Okay, it looks
Hello.
like,
Yeah.
yes.
Hi. Hi all. This is Paul Nyachai.
Yes.
We are working with the Challenge Initiative in East Africa. And just to maybe give a quick update, this is one of the Chapago programs in Tanzania. And we are working with the drug shops as part of the effort to try and improve access to family planning. So we are really interested, and I think we're glad to hear some presentations on the work in the pharmacy space, and we'll be following up just for more partnerships and coordination in that effort. Thank you.
Thank you so much, Paul. Yes, we had definitely reached out to the TCI project as well. Unfortunately, I understand a lot of field activities were going on. Hopefully, we'll have a future opportunity to present, but I do know there's a lot of good work happening, especially in terms of reporting for family planning. So thank you for that, Paul. Anyone else from the group? Okay, there being none, I think we can move on to now the discussion session. The way I intend to do this, and Andrea will be co-facilitating with me, I would like to read some of the questions that are there on the chat, maybe start with those ones first, allow the speakers, the facilitators to answer those questions, and then see if we'll have time for further discussions. So I see the first question was from Somia for Monica, which is what kinds of drugs do the Healthy Shield participants get access to at the drug shops? And can you also describe the rules and regs around this access? I do see there was an answer given by Sarah. Somia, was this enough, or would you like to get more details? Or Monica, would you like to add to that, please?
Yes, please. Can you hear me?
Yes, Monica, I can.
Okay. First, I would like to apologize that I didn't make myself clear. So taking you back to my presentation, when I said drug shops / pharmacies. So as we know that for a very long time, adolescent girls and young women have access to contraception from these drug shops. However, not all contraception products are being allowed to be provided in adult shops. And the prescription was, for example, the oral contraception pills and the injectables are being allowed to be dispensed at the pharmacy level. So for those clients who visit adult shops, since we have already trained the adult owners and dispensers on how they can provide correct information to our clients, they usually direct them to nearby healthcare facilities. For example, we have learned that the emergency contraception pills are being provided by ADOs. However, this is not allowed by the regulations in Tanzania. So with our clients, we tell them whenever they meet such kind of client who is looking for emergency contraception, it's much better to connect them with the nearby healthcare facilities, because without a proper contraception plan, they still remain, they are still susceptible under the unplanned or unwanted pregnancies. So with regard to the regulations, it's only the barrier contraception, for example, the condoms that are being allowed to be dispensed at the ADO shops. However, there are products, the prescription medications that are being provided by pharmacists, and also our clients are being linked to pharmacists for such kind of services, especially with the contraception pill, the oral contraception pills for refills. So they visit the pharmacists for such kind of services. I don't know if that makes sense, or if there is any questions, you're welcome.
Thank you for that, Monica. I mean, I think it was quite, explanatory, but we'll move on to another question and, try to see if Soumya adds further comments, or Soumya, if you'd like to unmute and just share anything, please feel free to do so. The next question was from Clancy asking Dan, and I think that has been responded to by Dan. Clancy, do you have anything else?
No, I don't. I think that was quite clear. Thank you, Farhan.
Okay. Welcome. I see one question from Mariam, which I think, will sort of open it up slightly for a broader discussion, and we'd love to hear thoughts from people. She says, it would be amazing to hear how to ensure business sustainability if prices for commodities are low, largely due to donor funding. Is there anyone who wants to respond to that? I think this was more a general question for participants on the community of practice. I see no. Anyone wants to take a stab? I mean, I think I can perhaps, share one idea to answer this, and maybe that will incite some discussion for other people. So Mariam, I mean, I would say, for example, one of the things that, can be considered, especially when you're talking about, because I think, especially when it comes to, this element of business sustainability, perhaps, it affects even more the lower health facilities, the drug shops, maybe even some pharmacies, because those are ideally micro businesses, right? They're working at a very low level. So, competing sometimes with, free products may be a bit of a challenge. Of course, when you have the bigger pharmacies or the slightly higher health facilities, perhaps, the market that they are targeting is more of the upper wealth quantiles. But I think for the micro businesses, something that can be tried, for example, is if you want to lower the prices of your commodities and be able to, provide a price that is at least somehow comparable or something that's affordable, especially at the last mile. I think one of the things that can be done is if you are able to do pool procurement, like if, different micro sort of businesses, so the ADOs or the pharmacies, if they're able to, let's say, come together, and I think some of that work has been done, I believe, under Shops Plus previously, and some of that work I think we are also exploring under FHM Engage currently in country, is that are you able to group these micro businesses together in terms of associations, and then be able to set up some kind of mechanism that they can pool their orders and get them from the supplier at perhaps a lower rate because it's pooled, it's bigger volume. So that's one idea that comes to mind that I would share in response to your question. I'm sure there are more. Since I see no one wants to, add to that, I'll move on to the next question, which was from Andrea to Dr. Amon, to understand a bit more about the actual intervention. Was it product pairing of HIV STKs and contraceptives? Dr. Amon, would you like to respond to that?
Thank you, Farhan. So the intervention basically is the loyalty club, that is the Malkia Club, and that is being attached to the ADOs. So we have ADOs that implement Malkia Club vis-a-vis ADOs that present business as usual. So in those ADOs which implement Malkia Club, the girls have an advantage of earning prizes by shopping, but also have an advantage of observing these real-time commodities, looking at videos in the tablets, and which is not being happening in the business as usual ADOs. So that is it.
Okay, Andrea, does that answer your question?
It does, absolutely. Thank you, Dr. Aman.
Thank you.
Okay, moving on to the next question by Soumya to Dr. Stephen. Can you comment if the results from your analysis align with national costed implementation plans? In other words, how might we contribute to national resource allocation since these are done at a highly aggregated level? I see, Dr. Stephen, you did respond, but anything you would like to add?
No, just that I think, a study of this kind was really designed to look at the feasibility of using these tools in a fairly limited number of sites. And I think the advantage, just something, and I wrote here about ABCM, is that you can do it in a much larger number of sites, and you can really project out for the entire country. Because we've only got, we're only looking at 9 sites in Tanzania, it's very hard to say anything about the conclusions about what this means for the whole country. But as we expand and as we are able to use other approaches and validate the approach that we used in this study, I think we would be able to make much clearer conclusions at a national level, particularly if we used an approach like ABCM, which I think we've also been discussing. Thanks.
Thank you for that, Dr. Stephen. And I think, this is quite interesting to consider, especially again, in the context of Tanzania, because we are having currently a lot of in-country discussions around universal health coverage, universal health financing, having a universal health insurance. And I think, when we're thinking about how that will cover family planning services, what will that look like? There's definitely room for more of this kind of work to be done to inform those processes. I see there was a question from Dr. Jennifer, but I see also that Mary had already responded to it. Mary, would you like to add anything else?
So just to elaborate.
Mary, we are getting an echo again.
Is that better?
Yes. Yes.
Okay, perfect. So yeah, just to elaborate, because of the sensitivity of our model, we always work closely with Ministry of Health, especially if we are scaling up. Because of those two issues, the issue of reporting and the issue of supervision. As the community health workers are still considered as government cadre. Maybe not all of countries of operation. Some countries, they are not yet paid. So we're a little bit free to have them under private sector. But usually the supervising party are two parties, us as a company, the quality assurance team, but also the Ministry of Health, according to the department that we are following, according to the project that we are conducting. And also we provide information through handing the reporting tools to the community health workers, that they also give it to the facility, and then it end up at the Ministry of Health and the country of operation.
Okay,
Okay,
thank you.
thank you.
Mary, if you can mute yourself. For some reason, our mics are connected. When you unmute, I start hearing an echo. But yes, okay, thank you for that. I think as far as my question goes, there's a last one that has been asked by Cindy and seconded by Andrea as well, that with so many interesting private sector initiatives in Tanzania, I wonder how proactive the MOH is currently in stewarding the RHFP health market and looking for opportunities to leverage the private sector's role. Is there anyone who wants to comment on that? I see.
And
yes, Andrea,
Farhan,
go ahead.
yeah, if I could just jump in and actually maybe even expand the question slightly. So definitely building on Cindy's observation about, both need and opportunities for the government to assist with stewardship, but also when we think about stewardship, we also think about how other entities can come together to steward market development activities. And so that would be maybe a bit of a food for thought type question, not to necessarily answer at this moment, but across this wide range of activities, what do local partners and implementers see as potentially opportunities to come together to work with the government or work together in some way to steward for positive change?
Thank you for that, Andrea. And I mean, I definitely would love to hear from some of the people, but I think, just contributing a little bit because of the work that we are doing, even as FHM Engage in country. I mean, I will say that, when it comes to the programs within the Ministry of Health that are private sector sort of, at least they have that private sector thought process, they're thinking in that direction. I actually think the RCHS, the reproductive and child health section that oversees, family planning as well, and it's actually a unit now, I believe, within the MOH, is actually quite forward compared to other programmatic areas in terms of wanting to collaborate with the private sector, in terms of wanting the private sector to come on the table and do, discussions, share data, etc., etc. I think there's definitely more work to be done in the how of it, in the sense that coming to that win-win that is for both the public and the private sector, allowing some sort of, creating that enabling environment for certain aspects within the private sector to thrive, especially for family planning. And that is sort of the work that we are doing in country currently. But I would definitely want to commend that of the many programmatic areas, they are quite ahead in terms of thinking about total market approaches, private sector, etc., compared to other areas. But happy to hear from other local actors as well. Monica, would you like to share? Because I know Monica, for example, works very closely wherever she is doing her family planning work. She works very closely with the public sector. Monica, would you like to perhaps share your experience about that? Okay. Sorry for putting you on the spot, Monica. Maybe you weren't ready. But yes, anyone else who wants to share some thought processes around that?
And Farhan, as people are maybe thinking about that and recognizing that we just have sort of 4 minutes for wrap up now, maybe you and I'll take the wheel and just ask a couple more things and then wrap up. So as I guess a last question, but a final sort of related question for the group. And it's honestly the perfect segue into the next slide. So Elizabeth, if you want to advance to the next slide. One of the things that really occurs to me as we started out with Sarah Elb's presentation on, market description and highlights and starting to hint at root causes of market underperformance, and then hearing from others throughout, is the topic of market intelligence. And again, as I think across all the implementers and all the different projects going on, and you're all focused in different areas, are there types of market intelligence that piqued your interest from Sarah's presentation? Are there types of market intelligence, market data, like using the latest data from FP Market Analyzer, for example, that would facilitate your efforts in your own projects? And so again, not necessary to come off mute at this moment, but along the lines of what you now see on this question page for all of you, we'd very much invite you to, and I want Farhan to elaborate his thoughts on this, but very much invite you to type your thoughts in the chat or send an email to Elizabeth, who's our colleague on this, to, to share your thoughts with us about this topic of market intelligence, whether it's on the supply side, the demand side, what stewardship activities there are, et cetera, because certainly with the FHM Engage project, we are very dedicated to addressing one of the challenges of market development, which is market intelligence, right? And most specifically, often for the private sector, private actors are often somewhat reluctant, or they have more barriers to investment because they need data about the markets that justifies their investment. So that would be kind of an added question really to these, and then also just to these couple of other questions that we have on this page. Would you like to continue this Tanzania focused conversation in some way? And again, I'll let Farhan comment more. We're certainly thinking with this localized approach that it could be an in-person type meeting. It would definitely be something that we think FHM Engage Tanzania could help facilitate, but would also welcome other partners. And then just related, are there topics or tools that people would have interest to hear about, again, related to these community of practice calls? So just sort of your stream of consciousness thoughts on any of those, please feel free to chat your notes or email Elizabeth. And with a big thanks, I'll turn it over to you, Farhan, for any closing remarks.
Thank you so much for that, Andrea. I mean, yes, I've also put my own email on the chat as well in case people have any specific questions. We are more than happy to, either host a discussion virtually or physically for those people who are in country in Tanzania for us to continue these discussions. Please do share your questions. I definitely think, market intelligence is a very sort of important topic. The whole issue around private sector data, how it is used, how is it collected, who wants how much of it. I think, that really needs to be a broader discussion and needs a lot more input. So we are more than open for that. Please feel free to send your thoughts and we can definitely facilitate. And thank you so much again, today to all the presenters, all the participants. We had to change this, as Andrea mentioned, but still everyone participated and contributed quite a bit. So thank you for that. Andrea, do you want to make that announcement?
Yeah, thank you. And just the very last announcement is that our March meeting will be right at the end of the month on the 29th, and the country of focus will be Pakistan. So spread the word, and we'll be working with Pakistan colleagues to identify speakers. But again, we're happy to hear from everyone and appreciate your support. An email will go out with access to the slide deck and the recording. And just a final thanks to Farhan, who is an amazing leader in this realm, and Elizabeth, who is behind the scenes making so much happen. We're really appreciative. And thanks everyone for attending today. This was great. And all our speakers, thank you.
Thanks, everyone.
Have a great rest of your day or evening. Take care.
Thank you.
Bye.
Thank you, everyone. Thank you, Andrea. Thank you, Farhan. Great session.
Bye.